All right, good afternoon, everyone. It looks like we have all of our participants, or all of our panelists signed in, and I'm not sure if Jonathan was able to call in or not. He has something to attend to, and he's planning on listening in and sends his greetings and apologies that he couldn't start us off today. But hi, I'm Amy Haddad, the Director of Public Policy and Government Affairs at AMCHP, and welcome to today's call. So as usual, housekeeping, if you have any questions that you're going to type into the chat, we certainly encourage you to do it to make the selection for all panelists and attendees so that everyone can read the question. And then if you have any other technical difficulties during the call, you can always email Jess Cohen, jcohen@amchip.org, or send a message to panelists. So today, starting with welcome, I'm going to tell you about a new AMCHP resource. We'll have our updates from MCHB and CDC. We're going to have one of our AMCHP colleagues share about some personal experience she's had with COVID-19 in her community. We have a lot of great topics for Q&A today that came through in registration. Thank you all for filling those out. So we will get to those as well. I should start by saying that there's not much of a legislative update because Congress is still deciding how they're going to proceed on future COVID-19 legislation. As we all know, because we've had these calls every 2 weeks since then, the House passed the HEROES Act back in May. The Senate still hasn't put something forward. They have been holding a lot of hearings in both the House and Senate in various committees on various topics and aspects of the COVID-19 pandemic, including a pretty good one on Tuesday in the House Energy and Commerce Committee that featured Dr. Redfield from the CDC, Dr. Fauci from NIH, Dr. Hahn from the FDA, and Admiral Giroir, whose name I never pronounced correctly. And so if you have some time, which I know none of us do, but what I often like to do is watch these hearings on in the background, and they're recorded too. So check that out because I think there were some really good questions and topics covered there, including some of the same topics that we've been covering here on a lot of our calls, including things around like school reopenings, which I will say they pretty much, the answer to the repeated question about that was around having to make those consultations with local officials. But I think it's good to hear what's coming out of the various different federal agencies at this time. The other big legislative item, again, specific to health, is the appropriations process. So originally the Senate was going to start marking up their appropriations this month. That got pushed aside, and now they're saying may not even happen until September. And the House is going to start their appropriations markups after July 4th. But again, with the Senate not even doing theirs, we're almost certainly headed for some sort of continuing resolution, and ongoing conversations I know are happening about budget caps and also how to incorporate emergency spending that we've needed to add during the pandemic. Before we move on to our federal partners today, though, I did want to make sure that you all knew about a brand new AMCHP resource on postpartum Medicaid. The link is here. We were really proud. This was a project that probably was about a year in the making, and I want to give a lot of credit to my colleague Allison Northrop, the Associate Director for Government Affairs, who's still out on maternity leave, but she did a lot of work on this as well. And this is really about frequently asked questions and different facts to know about the importance of continuing the Medicaid postpartum coverage for 12 months postpartum. Right now in a lot of states it ends at 60 days. So please take a look at these. We hope that you'll find them useful because I think they came out really well. With that, I will turn it over to Dr. Warren. And actually, I'm going to stop for 1 second to note that Jonathan has joined. Jonathan, did you want to say anything, or are you going to be in listen-only mode?
Hey, thanks, Amy. Can you hear me?
Yeah.
Unfortunately, I'm going to be primarily in listen-only mode, but thank you for leading the meeting. And again, as always, thank you to our MCHB partners and CDC partners for your leadership and dedication to this call to helping us to navigate through this pandemic, and really appreciative of the leadership demonstrated through our members during this process. So thank you, and I'll turn it over to Dr. Warren.
Great. Thank you, Jonathan and Amy. It is good to be able to join you all as always and provide updates from the Bureau. I want to start, I know we tell you all thank you a lot, but for many of you, you're heading 3.5, 4 months into the response to this. And while you all are so necessarily focused on taking care of MCH populations, I do want to make sure you're taking care of yourselves and your families. And I know you are focused on taking care of others, but really want to give a nod to making sure that you're taking care of yourselves. We care about you. We know that you have to be safe and well to do this work. And between the pandemic and the various concerns that have arisen in communities across the country as we all try to grapple with the impact of racism and our response in that, all of those things together take a toll. And I want you to know that we recognize that, and we so value you and your well-being. And so we hope that you continue to stay safe and well throughout this process. So if we can advance to the next slide, just a few updates to share with you. Wanted to make sure that everybody knows about Well Child Wednesdays. So you'll remember that a few weeks ago, our colleagues at CDC published in the MMWR about declines in pediatric immunizations, both vaccine ordering and administration, after the emergency declaration. And what we know from hearing from a variety of stakeholders across the country is that well child visits are also down. And so folks are really trying to address this in a number of ways. It so aligns with the work that you all do in state MCH programs. And so last week, June 17th, HRSA started launching a social media campaign called Well Child Wednesdays. So every Wednesday for 6 weeks, we will be promoting well child visits and bright futures and immunizations and different aspects of well child care on HRSA social media, so Facebook, Twitter, and Instagram. So the ask is that if you don't already follow that, to follow it, encourage your media departments and your agency to follow us and help cross-promote that work. When we look at who shared or retweeted those posts in week 1 and 2, there were many, many health departments across the country, state health departments who did that, a number of family organizations, and other MCH stakeholders. So we really appreciate getting that word out. The very first week, we had something like 55,000 Twitter impressions and I think close to 50,000 Facebook impressions. So this is helpful to get the word out, and we're using the hashtag WellChildWednesdays as well. So appreciate any help that you all can give us in encouraging your agency, media partners to help us get that word out as well. And you can just see on the right-hand side, it's an example, a screenshot of the tweet from yesterday. So next slide, please. Our staff in the Division of State and Community Health wanted me to make sure you were aware that the long-awaited proposed draft to the block grant guidance is out. So it was posted in the Federal Register on June 15th, which starts a 60-day comment period that is open to comments from anyone in the public. That will close on August 14th. And to get a copy of that guidance, you need to email the email address that is shown on this slide. And these slides will be available to you, but it's paperwork@hrsa.gov, or you can call 301-443-1984. That is an established process. We can't change it, so I can't en masse send it out to all of you, which might be easier. But there is a process for these kinds of public notices and comments. So it is easy, though, to request it, and you'll get back a draft of the guidance and have the opportunity to comment. And again, those are due by August 14th. Next slide, please. Just a couple of things to point out about the guidance. You will notice one major change is that we're asking states to talk about emergency preparedness reporting in the narrative. So talking about your planning and preparedness work. And we're doing that because we realize that Title V programs often are called in to really provide that MCH expertise when there's an emergency, and helping both at the state level and community level think about how to respond to that from the MCH perspective. And so this is an opportunity really for you to think about your capacity for responding to emerging public health threats and disasters, and specifically to help your states respond to to those from the MCH perspective. It also will give you an opportunity to look at how you are integrated in your state's existing emergency operations plan. So is Title V part of the emergency structure? How are you involved in preparedness and planning activities and those sorts of things? So this is something that has come up a number of times throughout the last few years, but certainly very timely now with the pandemic response. And we know that states are, in many states, Title V programs are already involved. This just gives you the opportunity to tell us about that, but also to help identify any capacity concerns. Next slide, please. So we welcome your comments, any comments you have on any of the proposed updates. We will then be taking those comments, taking all of them in, reviewing them, and releasing the final guidance later this year. And we really rely on your leadership and your experience and your perspective to make the guidance as strong as it can be. So wanted to let you know that's out. Again, August 14th is the deadline for response. You'll have the email and phone number on the slides if you'd like to request a copy of the guidance, and we look forward to hearing back from you. And I think we can advance one more slide. Yep, that's it. Thank you so much.
Great. Thank you so much, Dr. Warren. And now I'm going to turn it over to our CDC colleagues. Kriya will go first, and then you'll turn it over to Sasha. Thanks.
Hi, thanks. This is Kriya Perrine. So I'm just going to give 2 quick updates and then turn it over to my colleague, Sasha Ellington, who's going to share some new information from a CDC report on COVID-19 and pregnancy. So the first announcement, which some of you may have already heard, is that CDC is very excited to announce that Dr. Karen Remley will be joining us as the director of the National Center on Birth Defects and Developmental Disabilities. So she will join us in this new role on August 16th. Some of you may know Dr. Remley. She's bringing to CDC more than 30 years of experience in public health and healthcare. She obviously has played a critical role for children in her previous role as Chief Executive Officer of the American Academy of Pediatrics, and has served as Commissioner of Health for the Commonwealth of Virginia on several different occasions. So we will be very excited to welcome her to our CDC family. And then the one other update I wanted to give is that CDC released some new web content today related to individuals who may be at increased risk of a severe illness from COVID-19. So there's a number of conditions that affect people of all ages, which would obviously include children. And then there's some specific language about children who are medically complex, have neurologic, genetic, metabolic conditions, or who have congenital heart disease as likely being at higher risk of severe illness. So you can find more information on those conditions as well as there's a lot of background material on the literature reviews that went into informing those updates on our webpage. And with that, I will turn it over to Sasha. Thank you.
Hey, good afternoon, everybody. I'm Sasha Ellington. I'm with the Pregnancy and Infant Linked Outcomes team in the Epidemiology Studies Task Force of CDC's response. Let's see, can we go to the next slide, please? So I'm going to talk a little bit about severity, COVID-19 severity in pregnancy. As Kriya mentioned, we just released a report today that shifts a lot of our language around this. So I have a couple of just background slides on where we are with the literature, and then some of the key findings from the report that came out about an hour or so ago. So there are physiologic changes in pregnancy that can increase risk of severe illness, and severe disease has been associated with other viral respiratory infections of pregnant women. But up until now, initial reports were unclear about COVID's impact on pregnant women. Recent studies are helping to define this better. Move to the next slide. So there was a recently published prospective cohort study conducted from mid-March to mid-April at 5 medical centers in New York City. In there they had 241 pregnant women who were positive for SARS-CoV-2. Testing practices varied by medical center and over the time frame due to test availability, evolving epidemiology, and hospital policies. 89% of these women, though, were admitted for obstetric indications, and the remainder were admitted for GI or influenza-like illness. And then over 60% of them were asymptomatic when they were first tested. However, nearly a third of those who were initially asymptomatic did develop COVID-19 symptoms during hospitalization. This study found that a body mass index of 30 or greater was associated with COVID-19 severity. However, insurance type, age, race, and ethnicity, and other underlying medical conditions were not associated with COVID-19 severity in this study. Next slide, please. So in this study, there were 245 live-born neonates that were born to 241 women. There were 236 live-born neonates that tested negative, that were tested for SARS-CoV-2, and 98% of them tested negative. The preterm birth rate in this cohort was 14.6%, and that's higher than among the general population. And the authors noted that there was a statistically significant linear trend between COVID-19 maternal severity and the risk of preterm birth. Next slide. So now I'm going to provide a brief overview of the report that came out in CDC's Morbidity and Mortality Weekly Report today. It's entitled Characteristics of Women of Reproductive Age with Laboratory Confirmed SARS-CoV-2 Infection by Pregnancy Status. You can go to the next slide, please. So for this analysis, we used data from CDC's COVID-19 surveillance, which includes a variable on pregnancy status, but does not include other pregnancy-related information, such as trimester of infection. We limited the analysis to women 15 to 44 years of age with laboratory confirmed SARS-CoV-2 infection reported from 50 states, New York City, and DC. From January 22nd to June 7th, there were over 300,000 cases of laboratory confirmed SARS-CoV-2 infection in women of reproductive age, defined as we use 15 to 44 years of age, reported to CDC as part of the COVID-19 surveillance. And of those, 28% had available data on pregnancy status, and of them, just over 8,200 or 9% were reported as pregnant. This percentage may be affected by more frequent healthcare encounters among pregnant women, which increases opportunities to receive SARS-CoV-2 testing, missing pregnancy status among women, or increased screening in pregnant women. A number of inpatient obstetric healthcare facilities have implemented universal screening and testing policies for pregnant women upon admission to the labor and delivery unit. Can we move to the next slide, please? So here are the main findings from the report. Among pregnant women, 31.5% were reported as hospitalized, compared with 5.8% of non-pregnant women. 1.5% of pregnant women were admitted to the ICU, compared to 0.9% of non-pregnant women. 0.5% of pregnant women received mechanical ventilation, compared to 0.3% of non-pregnant women. And then the percentage of those who died was similar by pregnancy status. So we did see some differences in age, underlying conditions, and race ethnicity between the pregnant and non-pregnant women. So we calculated adjusted relative risks, adjusting for those variables. And when we adjust for age, presence of underlying medical conditions, and race and ethnicity, pregnant women were significantly more likely to be hospitalized, with an adjusted risk ratio of 5.4, 50% more likely to be admitted to the intensive care unit,
would be without,
and 70% more likely to receive mechanical ventilation. And then 16 deaths were reported among pregnant women, and again, the adjusted risk ratio was also not significant and very close to the null value. So we'll note that this the hospitalization relative risk, we think there's a number of factors driving that, including the universal testing policies admitted in hospitals, but we were concerned by more concerned by the 50% increased risk of ICU admission and the 70% increased risk of receipt of mechanical ventilation. Next slide. So this new report includes the largest U.S. cohort of pregnant women with lab-confirmed SARS-CoV-2 infection to date. There are challenges on interpretation of the hospitalization data, as I said, as an outcome for severe COVID illness in pregnant women, since data weren't able to distinguish the reasons for the reasons for hospitalization, whether it was obstetric indications or COVID-19 related indications. So therefore, differences in hospitalization by pregnancy status might reflect the lower threshold for admitting pregnant patients or for the universal screening, the labor and delivery unit. More complete data are needed to assess if SARS-CoV-2 infection and pregnancy is associated with adverse pregnancy and neonatal outcomes. We do not currently have the data to answer these questions, but hope to have those data soon. However, results from this study suggest an increased risk of ICU admission and mechanical ventilation, which are distinct proxies for severity in pregnant women compared to non-pregnant women. But you will note that the absolute risk of these outcomes was rare among both populations. Next slide. So we have a number of next steps. This is kind of the tip of the iceberg in terms of looking at these types of data. And this gives our first kind of signal that pregnant women might be at increased risk for severe illness. There are several cohort studies that we are currently working on, including some retrospective electronic cohorts that will be leveraging electronic health records, and also a prospective community cohort plan. These studies will assess incidence and seroprevalence of SARS-CoV-2 infection and pregnancy, and also among pregnant women, look at predictors of severity of disease, such as underlying medical conditions. We're also collecting surveillance data on pregnancy and neonatal outcomes with our pregnancy surveillance module and leveraging the Surveillance for Emerging Threats network to collect those data. So we have started to collect data. We have over 30 states and territories that have opted in to participate in that surveillance effort, and hope to have data to report out in the near future. We're also leveraging some existing pregnancy surveillance systems, such as the Pregnancy Risk Assessment and Monitoring System, by developing a supplement that will be used to assess knowledge, attitudes, behaviors related to COVID-19 among women sampled for PRAMs. And then COVIDNet, which is a hospitalized, is a data set of hospitalized COVID-19 illnesses, is being used to look at hospitalized pregnant women and factors associated with that. So, and next slide. That's my last slide, so thank you.
Wonderful. Thank you so much, Sasha. And I'll just ask people, if you start having questions already for the Q&A session, please feel free to type them into the chat box to the all panelists and attendees if you go in that drop down. And now I'm going to turn it over to AMCHP intern Tanisha Mundeston, who is going to share a little bit about some experiences in her own community in the Eastern Shore of Maryland with COVID in the community. She had the opportunity to share this with some of us recently, and we just thought it'd be really wonderful to let her share with all of you, because I know sometimes we're talking about, we're talking about things on a big scale, and it's a powerful reminder to know what's going on at a personal level. So Tanisha, I'm going to turn it over to you.
Thank you, Amy and the COVID team, for allowing me the opportunity to speak about my personal experiences with COVID within my own community. I'm from Wycomico County, Maryland, and currently we have over 1,000 cases and 40 deaths as of today. And I just want to talk about how this has impacted the immigrant/migrant communities in my area. So I'm Haitian American, so this is the community that I will most likely be speaking about, but this also applies largely to the Hispanic populations that live in my area as well. So I want to address 4 things: the language barrier, testing, information sharing, and pregnancy. So first, the language barrier. When COVID first impacted my area in Salisbury, Maryland, most of the materials that were distributed were in English, and many people in my community, Haitian community, do not speak English or have limited speaking abilities and reading abilities. So it was very difficult to get the correct information out to people, which led to more people not understanding what it meant to social distance or the differences between quarantine and isolation. And I suggest that there be better translation and interpretation services provided by people who are culturally sensitive or aware, especially when it pertains to transitioning to death, I have known of a few members from my own church and family members who have passed away from COVID-19. And when you are not a native English speaker, you have limited English abilities, and you're surrounded, when you're about to pass away and you're surrounded by many healthcare workers who are speaking English, you're in a confused state, an isolated state. It's a very traumatic place to be, not being able to be surrounded by your family and loved ones during this time. In terms of testing, the word quote unquote essential workers is very difficult to process what that actually means. You're essentially putting your life at risk. I am in an area where we have many poultry farms such as Purdue, Tyson, Mountain Air Farms, and the poultry industry is huge here, and that is where a lot of Haitian workers and Hispanic workers are employed. So not only are they facing environmental health risk because of the factory working conditions, but because of this pandemic, they're also experiencing a lot of health risk, their own health risk. They're at higher risk for contracting the virus due to the tighter spaces and just being around a lot of people makes it very hard to social distance. It got to the point where Governor Larry Hogan of Maryland had requested the assistance of the CDC in my area because the case rate for COVID was increasing at an alarming rate that we did not expect at first. And so most of the cases that we've experienced stem from tracing from family members and people who have worked in the poultry industry. And alongside with testing, there's a lot of misinformation that has been going around, particularly through WhatsApp, which is heavily used in my community. And it's important to debunk the misinformation surrounding testing and COVID in general by using healthcare workers who speak multiple languages, such as Haitian nurse practitioners, nurses, and Hispanic doctors and nurses as well, so that the community feels like they can trust and have rapport with people that they actually trust to relay information that is necessary. It's gotten to the point where we don't really know who is being impacted because people are afraid to get tested. There's things that people believe that if they get tested, that's when they'll get the virus, or people fear that if they do test positive for the virus and they're no longer able to work, how they're going to provide for their families. This is also a high concern for those who are undocumented, as they might not be able to access as many resources as someone who does have documentation. Now, in terms of information sharing, it is important to distribute information beyond flyers because not everyone has the ability to read English or in their native language. So using local resources such as local radio stations or social media platforms or even WhatsApp is essential for helping people understand the context that we are living in, especially as states start to reopen. I'm seeing videos of people going to the beach and not wearing masks or not practicing social distancing. So just because states are reopening, it's even more critical now for people to know what social distancing looks like. And an example of information sharing would be as churches are reopening. My youth leader at church is a nurse practitioner, and what she has done is she created a short clip that's about 2 minutes where she went inside of our church and she used a few of our youth members and kind of walk through what it looks like to social distance within the church by starting from the parking lot of the church to entering the church and entering the sanctuary, and also how to use the bathroom, continue to use hand sanitizer, and also how to exit the church. So using these short clips can target people who aren't able to read flyers and just share information in a short and accessible way. In terms of pregnancy, so I've known several women who are pregnant or have been pregnant during COVID, and it has truly been an experience for them. First, I want to talk about mothers who are undocumented. I'm from a mixed immigration status family, and my aunt who is undocumented, gave birth about 2 months ago, and it was a very different experience for sure. They tested her when she arrived at the hospital, and she tested negative, but she is not a native English speaker. Her and her partner's English speaking skills are very limited. So having to figure out the paperwork, constantly calling, us back and forth to figure out how to kind of navigate the pregnancy, in a way was a bit difficult. Yes, translation and interpretation services are available, but it is very different talking to someone you don't know on the phone versus someone that you know. And secondly, I want to talk about mothers who test positive for COVID. So there is a woman at my church who is the aunt of one of my youth members at church, and she also gave birth a few months ago, and she gave birth to a baby boy, and she tested positive for COVID. She was asymptomatic, so she had no idea. So she was very shocked when she arrived at the hospital and tested positive for COVID. And her son was also born with respiratory issues, so he was in the NICU for a few days, and it was a very traumatizing experience for her, because even after she was released from the hospital, she had to be apart from her son for a few weeks, and this was her very first child. So, and she is also a limited English speaker, so having to navigate, your own health concerns and what's happening with your own life and also with your newborn child was a very difficult space to navigate in terms of who to even believe advice from. For example, the hospital told her that it was safe for her to breastfeed, and that COVID does not would not transfer to her child, but family members, because of the fear and the spread of misinformation, were encouraging her not to breastfeed because she tested positive for COVID. So that is just one of the examples that I have for navigating COVID during pregnancy. And many of these subcategories that I've listed, such as the language barrier and testing, they all overlap in several ways. Next slide, please. Next, I want to talk about COVID and distance learning. So as soon as the Maryland Public Schools closed down for the rest of the year, I knew that there were several kids within my community who had the possibility of not passing the school year because just of their parents not being able to assist them with their work because of that language barrier. So I spoke to a few members within my youth, and we created the COVID-19 Learning Assistance Team, or CLAT. It was the 8 of us, and we assisted 22 kids this school year, and that is nowhere near the need that was within our community, but we were just grateful to be able to assist in any way that we could. And the assistance that parents are able to give their children, it's limited even if they have children who are learning English, but it's even harder for parents who have children and youth with special healthcare needs. I have a cousin who has some intellectual learning disabilities, and the assistance that he gets at school with the extra coaching for reading and English, it wasn't the same when we switched to a distance learning format. So he is going to have to repeat the grade level again, and having to explain that to my aunt of why it's necessary for him to do this has been difficult. I also have another cousin who has both physical and intellectual disabilities, and it has been hard. I've spoken to her mother about how difficult it is when teachers give certain tasks to do over distance learning, and it's just not, even as a nurse, she is a nurse, it's still difficult for her to carry out these tasks because she just not only isn't used to it, but feels like she didn't have the resources to prepare to teach her daughter in a distance learning type of format. So for community resources, this Wycomico County School Board continued to provide food for children who receive free and reduced meals, and I believe that this should continue during the current crisis that we are in. Hunger should be the least of the problems and worries, especially when trying to figure out how to navigate an online learning situation. Food and nutrition is definitely important to continue to progress in the best way possible. I also think it's important to get information about food drives out into the community. This is an opportunity to essentially kill two birds with one stone. I was assisting a food drive about 2 weeks ago, and it was also a place to give information about community resources, such as where to get testing and just other community resources on how to get help with utilities if need be. And I feel like when you set up structures where people can get testing site, a food drive, and community resources, it really gets the community involved and get people more aware about what is going on within the community. In terms of technology, when it first we first switched to a distance learning format, I was getting calls from parents that they didn't have access to internet, which I wasn't aware of, or any electronic devices, such as a laptop or tablet within the home for the child to continue with distance learning. Another problem that I saw that erupted was that when the packets for distance learning within my community first came out, they were only in English. And so there were no English, or there were no Spanish or Haitian Creole translations. And when they started about a few weeks afterwards with translating the materials, the translations, it was obvious that a human had not translated it. And while I love online translating resources such as Google Translate, they're not always accurate. And so even if a parent attempted to try to assist their child, the directions just did not make logical sense for them to understand what the directions were actually saying. And also there became a disparity in terms of how to submit that work. A lot of the submissions were through an app called Class Dojo. Some meetings were through Zoom, and many parents didn't even have an email to take pictures to send an email to the professor. So it got to the point where I had to, an example I can give is one parent had called me because they couldn't get into the Zoom app. So they WhatsApp videoed me, called me, and we kind of walked step by step on how, to get on Zoom. So these are just the simple facts that in general, people might think that families can just figure it out, but when there is that language barrier and when a family is not used to using technology, something that we might think as simple as using Zoom might become a hindrance to a child being able to learn to the best of their abilities. Lastly, I want to touch on physical and mental health. A lot of times, even in my own culture, the mental health of young children are not prioritized. Children are not used to being indoors. They're not used to, seeing their friends. And this is a very difficult time that we're in to try to explain what is actually going on. So I think at this time, it's very important to lean on the community-based organizations who give aid and support to people, especially in Hispanic and Haitian communities where mental health might not be prioritized in general. And to kind of tie it all together, many times it may feel as if the maternal and child health field or public health in general separates itself into silos, but public health is essentially built into everything and it's everywhere. The interconnectedness between distance learning within the immigrant communities and COVID, it's so vast and apparent during these times. And I just believe that it can have severe consequences. An example that I would give is a friend of mine's, her mom was hospitalized with COVID for about 2 weeks. She had very severe COVID, and she was in college at the time, and right now she's completing a course because she had to take an incomplete for it during the semester because of how heavy it was to just think about your mother being in a situation where she's really literally fighting for her life in the hospital, and you having to navigate your courses, your college courses was a very difficult thing. So just thinking about children who having to navigate distance learning, and with parents who are working at these poultry factories or working at hospitals who are essential workers and essentially putting their health at risk, but they're also, worried about school and worried about the health of their parents. So the interconnectedness and overlapping of everything, it's just important to keep this all in mind when thinking about public health, MCH, and just the situation as a whole. Thank you.
Great. Tanisha, thank you so much for sharing. And I believe Tanisha just graduated from University of Maryland, if I'm correct,
Yes.
and headed for an MPH at Johns Hopkins in the fall, perhaps over distance, but distance learning, but we've been so happy to have her as part of the AMCHP team this year and know that she's going to do amazing things. So thank you for sharing with everyone. So we have a lot of discussion items that have come up, again, through the surveys after the calls, through the registration, and just through communications, you know, during the 2 weeks in between these calls. So the first thing I wanted to do was, we got a specific question and I didn't know the answer with much detail, but I thought, hey, we're having this call today, this would be a perfect time to pose. So we are wondering, are any states using CARES or perhaps other emergency funding sources specifically to improve prenatal care? And wondering if anyone wanted to share experience on that. Oh, and I see that Vicky from Nevada, I'm totally calling you out, is on the line, or maybe it's one of your colleagues who signed in, but if you want to elaborate on that question at all. And remember, feel free to either type into the chat box or unmute your lines. So I'll pose the question, are folks mostly redirecting Title V funding that you already have to address COVID needs? Belinda, I'm going to call on you since you are on our board and you just typed in the chat box, so I know you're listening. Do you have anything to share from your experience in North Carolina?
You're talking specifically around prenatal care,
Yeah.
correct? And prenatal care from multiple areas. We're supporting our providers to use telehealth when possible, and to also, we've given guidance, especially to our local health departments that provide prenatal care services, guidance that, you know, for pregnant women coming into the clinics, you know, give them the option of staying in the car until it's time for their appointment. Try not to schedule it the same day you're seeing sick patients, or, you know, try to rearrange schedules and things of that nature. We have, there's a stakeholders work group that's been formed in North Carolina that's looking specifically at pregnancy and COVID, and they presented some recommendations to our maternal health task force earlier this month. So we're looking at those recommendations and having ongoing meetings to see what's the best way to share some of those recommendations more broadly. We've not used any specific funding at this point, other than, you know, we are one of the sites that has a maternal health innovation grant, and it does support the work of our maternal health task force. And nothing specifically for pregnant women that's related to the CARES funding, you know, except, you know, our CARES funding has been used throughout our state, but nothing specifically tracked for pregnant women at this time.
Great, thanks so much, and thanks for letting me volunteer you to respond. I see a response from Noel in Utah saying that you're they're using current funding and program staff, but that you haven't been able to tap into CARES funding. Is that something, I guess, you know, wondering if the emergency funding that's come through at the federal level has trickled down to you, or if you feel like you've been able to cover needs because of the flexible nature, excuse me, of other funding sources like the block grant. Other questions that we got, we, you know, continue to talk about guidance for returning to school. Oh, Noel is asking how to unmute. I think you can just unmute yourself, but Jess Cohen, is there something, are you able to unmute her?
Now. Okay, sorry about that.
Okay,
It wasn't coming up, and so I was like, I don't know how to do this. So I think at a higher level in our department, because it's so big, Department of Health, they're utilizing, my understanding, so hopefully I'm not misspeaking, but they are using CARES for like the higher emergency, just overall state, but I don't know if it's like trickling down to our level exactly. I mean, when I've needed some PPE, they've helped me get it, but I'm still paying for it. So it's not coming out of that CARES money, if that makes sense. I hope that I'm answering that properly.
Yeah, that's, excuse me, that's really helpful. Well, consider this, we'd love to hear it when you provide feedback either through the survey or just, email AMCHP staff directly. We are interested in continuing to hear how you're using either federal funds or funds that you, like emergency funds or funds that you already have for the program to support COVID response.
We've had a lot of our entities that we contract with say, why can't we get more money? And they feel like it should be spread out more, but we haven't been there. I think there's not enough, and there's concern with our numbers going up significantly. I think they want to make sure they can address the most emergent needs first.
Yeah, and that's, that brings to another point, a lot of conversations going around. And again, I heard this question coming a lot in some of the congressional hearings that I was watching this week, balancing the need between, what are the most emergency immediate needs today. And some people are like, wait, why are we even talking about preparing, for the next wave or the next pandemic when we aren't even done with this one? And it's trying to help convey that we need to be doing both simultaneously, or else we're never going to get ahead of the curve. Thank you also for sharing. So again, we continue to have a lot of questions about guidance for returning to school, especially for children and youth with special healthcare needs. And again, the answers that I was hearing still really are focused on having to make those local-based decisions, and obviously that can change based on the community. I'll tell you, with our own, my children are not yet in K through 12, so they go to like a daycare preschool environment, and our school has just decided that they're going to reopen, and I watched a very lengthy webinar yesterday about all the precautions they're taking, and it's really interesting to hear about how even the local guidance might say one thing, and the school feels like they need to take it a few steps further. Some schools are requiring masks for any child over 2, some aren't. Our school, especially thinking about children with special healthcare needs, they explain that they'll allow kids who have like full-time aides who are with them, but will not allow therapists who would just come in maybe for like speech therapy or PT/OT just for, a 45-minute or 1-hour session, because they're worried about that person coming in and out too much. So, realizing how that can really affect a family's decision whether they can return their child to school if they can't access necessary supports that they're trying to access. And that brings me to another question around guidance to returning for in-person visits around if you get Part C services, family support workers. I'm wondering if any of our federal partners have any thoughts on that, or on how the guidances are being developed to address those.
This is Kriya from CDC. I'll just jump in quickly and say we have all of the same questions and a lot of very active ongoing discussions. We're trying to look at examples from some other countries where maybe schools didn't close as actively or consistently, or have already opened, to see where we can learn more from other scenarios. We recognize that a lot of these decisions are being made in the next several weeks. And so, definitely lots of ongoing conversations. And I hope we'll have things that we'll be able to share, but I think we're not there yet.
Thank you. Some of the other topics that we received questions about regarding centering racism and equity in our response to the current pandemic. I know this is, at the forefront of our minds right now, and I'm wondering if any states have examples of how they've been able to ensure that the response is being led with, an equity lens, or if any of our federal partners want to talk about how you're addressing it. I don't know if Dr. Warren, if there's anything that MCHB, I see also there's someone who has raised their hand. Oh, Belinda. And she took her hand down. But go ahead, you're unmuted.
Is it Belinda or is it Dr. Warren? I'm just trying to see. Speaking. I will say the stuff we've done in North Carolina has been around, we have department-wide work streams focused on historically marginalized populations. So we've infused, equity and in trying to make sure we're reaching populations that are overly burdened with COVID in all of our efforts, with our educational materials, with who we're providing funding for testing and contact tracing, and in pretty much all of our areas, we really have tried to, we have a whole work stream that's just focusing on historically marginalized populations and trying to make sure that we are engaging individuals themselves and organizations that are working with some of our historically marginalized populations on a regular basis and engaging them in these discussions, as well as the outreach efforts that we're doing. And also along with the funding is going out the door. So that we think, it is a priority for us to continue this work. And those are just some of the examples of the things we've been able to do in our state.
Great, thank you.
This is Michael Warren with the Bureau. I think that, as you all know well, one of our biggest levers in addressing needs that states identify and health equity and addressing racism is certainly something that states have identified, but the biggest lever we have in addressing that is the block grant. So certainly lots of activities going on across the country as states have been addressing this even well prior to now, but certainly with the flexibility to adapt or adjust what they're doing. And then we also have very specific programmatic efforts that are aimed at addressing health disparities. So the largest one that comes to mind would be Healthy Start. So addressing infant mortality, but with a specific focus on reducing the disparity in infant mortality. And so with Healthy Start, as well as with many of our other programs, we've really worked with grantees to be flexible to meet them where they are as they innovate in thinking about how to reach various populations and how those needs might vary across populations, but supporting grantees where we've got the flexibility to do that. And then I think the other thing I would add is the new telehealth funding that was released through the Bureau, through those various projects, whether it's pediatric care or maternal care, public health systems, or the family engagement. Those include a lens of health equity with this work. So that's a way, even during the COVID-19 pandemic, we've been able to specifically address how we can center this work in equity.
Great, thank you. Here is a message in the chat box from Amy in Louisiana.
Actually, it's Becky. I couldn't change. This is Becky in Louisiana under Amy's name. Yeah, the one thing that I've really appreciated is that our leadership in Louisiana, our governor and our leadership from the Office of Public Health, they keep getting questions at press conferences about whether recent increases in COVID are tied back to the protests, and they've been very clear that the contact tracing has shown that it is not related to the protests, and they've really reinforced that fighting, being able to fight for justice is an important public health priority as well, and that people are not, that's not the reason that COVID is going up. So I think it's not just about racism and equity, but it's also about the opportunity to exercise your constitutional right to protest has been reinforced at press conferences in our state.
That's great, thank you. And then one other topic that we received questions about is around child welfare, child abuse, domestic violence. I know this is something we've been talking about since especially the lockdown started, and we know that, you know, people being kind of stuck at home had paved the way for increased possibility and incidents, and we've seen increased incidents of domestic violence and child abuse. Wondering if there's any work that you're doing in your states to actively address this, maybe working together with your welfare agencies. And while I'm waiting for a response on that, I will read. Belinda wrote, one critical area is ensuring that the funding is getting to organizations that are minority owned and minority led, or the trust is already in place. Absolutely. And we're already at 2:57, so I'll, you know, if anyone wants to chime in on the question around child welfare, please continue to do so. But I do want to flag a few things before we break for today. One is, of course, that our next call will take place in 2 weeks. We've already scheduled for July 9th and July 23rd. 2 weeks after that will be during the AMCHP virtual conference, so we will conduct our next COVID call in August a week later, so that it doesn't conflict with our own programming of the conference. And we'll put in a plug. Hopefully you all know that our conference has been moved to a virtual platform August 4th through 6th. And we're doing some really great and exciting preparation to make it as successful as we could in lieu of having an in-person gathering this year. And I also want to flag another opportunity which is coming up this Monday. We were pleased to be asked and to join Power to Decide and our Street Institute on a webinar highlighting Power to Decide's new Advancing Contraceptive Access Toolkit. And they also have these new interactive state policy maps for you to check out, but we will be joined, I believe, at least from New Jersey and Massachusetts so far, adolescent health coordinators. So thank you if any of you happen to be on the call right now, but please do join us for that call as well. We know, I believe this project is, you know, outside the realm of COVID, but certainly ensuring access to contraceptives during this time is an important topic as well, and I'm sure it will be discussed because you can't discuss anything without discussing COVID right now. So we have another minute if anyone has any last minute questions or thoughts that they want to add. Otherwise, I'll put this back up and really do ask you to fill out the survey because that helps inform some of our programming for the following session as well. Any final thoughts? Thank you again to all of our presenters today. Wonderful as usual to be joined by you. And I see we have 3 o'clock. So I'm going to sign off. Thank you again. As always, you know, reach out to any AMCHP staff with continuing thoughts as well. Have a great day. Stay safe.